but also regarding the time, if you don't mind, I think we move on to the radiation oncology perspective. So I ask Gabriela Studer, radiation oncologist from Lucerne in Switzerland, to present her case.
Thank you very much. It's my great pleasure to present today this of a 50-year-old lady with a high-grade UPS with initially metastasized disease. So she was diagnosed exactly 5 years ago with this high-grade UPS, histologically MIP1 90%, MDM2 negative, located on her left knee, distal femur with inter and extra auricular extension, and with initially metastasized situation on her lungs and the lymph nodes in the inguinal. So that's the imaging of the primary staging. See this disaster on her left knee, distal femur. See the lung mets, or some of them. See the nodal affection also in the PET. So how do you want to proceed in this quite desperate initial situation? If possible, please vote.
So as you can see, the first option had 5%, the second option, preoperative and neoadjuvant chemotherapy, 37%. That option, 21%, only 5% for the fourth, and answer 2 and 3 had 32%.
So that's what we did, what we decided in our interdisciplinary tumor board. We started with a neoadjuvant chemotherapy, doxorubicin ifosfamide, followed by radiation preoperatively with 50 gray in 25 fractions. The tumor was quite large, as you could see before, 300 cc, and this was followed by a surgical resection. The histopathological result showed 3 margins and 3% viable cells. So the treatment was followed by, again, chemotherapy. This resulted in a mixed response with pulmonary progression. So then the patient underwent the first wedge resection of the lung April 2018, a second one May 18, a third one July 18. And this was followed by palliative chemotherapy with pazopanib. And this translated again into a progression. See that? This initially known inguinal nodal metastasis grew. Switched to 3 cycles gemcitabine and docetaxel, and we saw a progression again. See these big lumps. Please vote if possible. How would you want to proceed in this quite desperate situation?
We have the answers. So 6% voted for the surgery of the left femoral mass, 19% pre-op RT for the femoral mass, definitive RT for femoral mass is 50%, and answer 2 and 3, 25%.
So I'm going to show you what we decided again in our board. We decided to go for definitive radiation in this palliative situation. The tumor was now 413 cc, quite a big mass. Please vote if technically possible. How do you want to proceed?
We have 17% for answer 1, 25% for answer 2, 17% answer 3. The majority, 33% for answer 4, and answer 1 and 2 have in combination, answer 1 or 2 have 8%.
Thanks, excellent. I show you our decision. In this case, we went for definitive palliative radiation with heavily hypofractionated schedule, 5 fractions with 7 grays to 35 grays to the GDV. We continued chemotherapy with nivolumab, again a mixed response and progression. Look at that, progression was in the brain, symptomatic brain metastasis. We treated this situation with postoperative radiation, 5x5. Then again, progression. This time in the contralateral leg, look at that. Because it is basically the same as initially in the left leg, now in the right leg. We continued with radiation again, 5 fractions with 7 gray to this quite large mass. Next chapter was the progression in the inguinal right-sided. We did the same, 35 in 5. So I want to show you the last follow-up as available of this patient, nearly 5 years later now. So the patient is mobile. The patient suffers of no relevant pain. She has some lymphatic edema on the distal legs. Left leg, 38 months post-treatment, no tumor. You remember, that's what we treated. Right leg, 5 months post-treatment, regression. Remember, that was 5x7. CNS, 27 months post-treatment, no tumor. That's a residuum, a kind of scar. No tumor visible. Left inguinal, 29 months post-treatment, no tumor at all. Remember this mass. Right inguinal, 8 months post, tiny residuum. Remember what we did 8 months ago. So it's quite amazing, I think. Facts known so far regarding radiation in sarcoma. So this is data from Herman Suit 15 years ago. He analyzed the local control of the definitive radiation of unresectable sarcomas. And he found when we have a sarcoma sized about 1 to 5 centimeters, we have a chance of about 50% to get some local control. When the tumor is measuring 5 to 10 centimeters, we have about 30% local control chance. When we have tumors larger than 10 centimeters, we have basically no local control of the radiation alone. That's the case for normofractionation. Other facts we know, radiological response following pre-op radiation, we know high-grade tumors show basically no shrinkage. And histopathological response following a pre-op radiation, we know high-grade median about 50% response. What we also know is this is a paper on stereotactic body radiation versus metastasectomy in patients with pulmonary sarcoma metastasis. We know, it's well known that tumors with a low alpha-beta ratio have a higher response at high doses in little fractions. That's what we know. And statement of another paper, radiation for palliation for sarcoma metastasis, hypofractionation experience. Theoretically, it's useful to use larger than standard fractionation to achieve significant cell kill by radiation, assuming an alpha beta for most sarcoma types of about 4. So take home message, heavily hypofractionated radiation may be an effective and well-tolerated option to consider in sarcoma patients with large metastases or unresectable tumor. So not considered here in this case report, of course, heavy ion therapy, experimental RT possibilities like grid lattice treatment. My own kind of comment on the case, we got wonderful response so far. That can change, of course. It's not a wonder, it's mainly radiobiology. Many thanks for your attention.
Thank you, Gabi, for this wonderful presentation. Based on the messages on my cell phone, it was quite thought-provoking. And first of all, I would like to give the word to the panel of radiation oncologists, Charles Cotton, and Tom Delaney, who are both giants in the field. I wonder what you say, mainly because of this hypofractionation case. Then, of course, they have to discuss the perspective with of additional therapy. Please go ahead, Charles or Tom.
Well, I can speak. First of all, Gabby, that was an amazing outcome for this patient, and I think it demonstrates that you need to be persistent with these patients with oligometastatic disease, and that being aggressive, long as the disease progression allows you to continue these local treatments, can often pay off. The question of whether you use radiation or surgery very much depends on the anatomy and the general state of health of the patient, and we always discuss those two options with all our patients when we're thinking about treating oligometastasis. In terms of hypofractionation, I have not used it very much, so I cannot say. But I have had, we have been using hypofractionation more during COVID, just because we get the patients in and out of the system a lot quicker. And interestingly, over COVID, I've had 2 patients, not with UPS, but with myxofibrosarcoma, who have had their tumors evaporate with large fraction of radiation. So there may be there's definitely some biology here, and I think that there is never any harm in using a hypofractionated regimen, provided it's the anatomy allows it. And I'm using it more than I used to, that's for sure. Tom, what do you think?
Well, lastly, first I'd like to thank Gabrielle for that presentation. Excellent patient care as well. I think we had a hint of the radiosensitivity of this particular tumor from the original pathology on the resection specimen, where there was only 3% viable tumor. In the paper we wrote with Lucina Keck and Herman Soot on the definitive radiation for these sarcomas, you mentioned the fact that we can control a number of patients, particularly if the tumor is small and the dose is above 63 gray. And I think the other point here is that aggressive treatment of oligometastatic disease, I think, is a new paradigm for treatment of many sarcomas. And I think your case illustrates well a very successful outcome. I think I would agree with using hypofractionation, and in particular, from a technical point of view, the use of the simultaneous integrated boost with a CTV, in this case, that would have been a budding bowel, but a second GTV volume within it is a very good technique to spare normal tissues. And I think what we all are using hypofractionation for metastatic disease to the lungs. We've published on excellent outcomes in patients treated with 50 gray and 5 fractions, and I think people are beginning to use even more hypofractionated schedules. So very nice case, well done.
Thanks a lot.
So if I understand you correctly, is hypofractionation used too few also for primary cases, or what do you expect there?
I think we're beginning to see some reports of hypofractionation for primary treatment. I think the use of 30 gray and 5 fractions has been published. I've seen reports of even more hypofractionated stereotactic treatment. I'm a little bit wary of adopting that for primary cases without further follow-up, but I think Cleveland Clinic has and the UCLA group have published on the use of 30 gray and 5 fractions as preoperative treatment, and their outcome looks to be quite good. I think in the past, the Polish group had published on 25 gray and 5 fractions, and the local control was a little bit lower than I think we would have liked. It was sort of in the low 80% range, but I think 30 gray and 5 fractions, slightly higher dose, and at least in phase 2 studies, that may be a trend for the future.
Thanks.
Joanna?
I just wanted to ask a question first. It was really a fantastic example how helpful radiation therapy can be even in a palliative situation. But referring to the Brian O'Sullivan paper on wound complications after preoperative radiation, did you see wound complications after the radiation?
Okay, maybe you remember in this case we went for normal fractionation preoperatively. However, we meanwhile also pushed by pandemic situation. We have a couple of about 40 cases. We did 25 in 5, and we have 0 wound complication. But that may be related to Bruno, the surgeon, you know. But still, we have no problems in this direction. No. Yeah,
that's very
it's
good.
very well tolerated.
Yeah. In this paper, I referred to 35% of patients had wound complications postoperative, and that's really a high amount.
Quite unpleasant. Yeah.
Okay. Thank you very much.
Welcome.
Axel, please.
Yeah, just a comment. I totally agree with Tom Delaney's sentence. When we have the chance, I have noted that in a lot of patients, like when we treat with induction chemotherapy plus induction radiation therapy, and it is the case in this UPS who's relatively chemo-resistant histological subtype, all pleomorphic in general, but UPS also. So 3% of tumor shrinkage of residual tumor cells after 2 cycles of doxorubicin and induction radiation therapy is more due to the radiation therapies than the 2 courses of chemotherapy. And we preferentially used radiation therapy in when the patient relapsed in a oligometastasis situation, even in large tumor like that. So what's happened is a primary tumor can happen in metastatic situation.
Thank you.
Jean-Yves.
Yeah, one question and one comment. First, you give only 2 preoperative courses of doxorubicin ifosfamide with radiotherapy. Is this your usual practice? Because usually we give 3 or a bit more in this type of situation. That was my first question. And the second one was about the symmetrical metastasis. I'm intrigued by this symmetrical sarcoma that we have observed several times, and I don't know how to interpret that. And I was wondering if people around the telephone were aware of this case of symmetrical relapses in the body. We've seen that several times. It's intriguing.
Okay.
Is there any comment for the 2 versus 3 pre-op cycles? So we keep that open. Of course, it's not standard. There's no standard pre-op chemotherapy, but of course this is not the usual part. But Joanna, please.
Yes, but usually 3 cycles are recommended according to the paper by Alex Gronke. He used in his study, he used 3 cycles pre-op.
Yeah.
I think in this case it was particular because it was this patient had synchronous metastasis from the beginning. So we are not in real neoadjuvant situation.
Right point. Good point. Yeah. And she had pain in the leg, so surgery was kind of let's do it fast. Yeah.
Okay, I got it. And it's impressive what quality of histological response you had, by the way, with only 2 courses.
Right, it's quite unusual. Yeah.
Very nice case, Gabriela. But just to add one thought. I think this case does not represent the majority of metastatic soft tissue sarcoma or bone undifferentiated sarcoma cases, because it seems the progression in each time was in one particular place of the body that you can offer radiation therapy in this site. But this is not the natural behavior of normal metastatic sarcoma, where in lungs we are seeing a lot of metastatic spread, and it's impossible to offer this kind of sequential radiation therapy over time. So I think I just like to emphasize that this is a particular behavior, very uncommon, and congrats, because yeah, the evolution has been extremely nice. But I mean, the majority of soft tissue sarcoma or bone sarcoma and differentiated bone, the behavior is not this.
Right.
Yeah.
Quite individual situation. We cannot just extrapolate and expect the same from other patients' reactions. Right. And also the treatment decisions, it was really kind of step by step. Let's decide together again, what can we do, what shouldn't we do. It was kind of very individual whole treatment. Yeah.
Beata, please.
May I ask? I would like to just make a comment, to this excellent response to radiotherapy. It's actually, we call it excellent, but usually this excellent response is associated with a very poor prognosis for the patients, because these are very aggressive sarcomas, which metastasize, so they die quickly, but they, they recover. So 3% is enough, so that the sarcoma recovers. So I'm always, cautious to call it. I prefer, if the tumor is not dead, it's low grade. Okay, the patient is not going to have the metastatic disease all over the place in the next couple of months. So this case is very unusual. It's also this, Jean-Yves, you mentioned those symmetrical metastatic disease. This is amazing. I've also seen like a few cases, and one was like almost low-grade dedifferentiated liposarcoma, MGM2 positive, and it did 2 symmetrical soft tissue metastases of both. I don't know why it happens. It's really amazing, and also I was really surprised in this case that suddenly, in symmetrical location the metastasis occurred. This case is also unusual in the sense that the brain metastasis is not really very typical, but most patients don't survive that far that they develop brain metastasis. Thank you. Thank you for that.
Jean-Yves, please.
Yeah, yes, one thing which you said, Beata, remind me of a paper which was never published, I think, by Peter Reichard from the ERTC data set, where I think the responders at 2 courses did less well than the stable patients at 2 courses in the long term in neoadjuvant setting. And that's very much what you say, which is responding fast, but regrowing fast. And we should have a closer look to that.
Very fascinating. Thank you so much for all. Yes, please go ahead.
Bruno, may I come back to the initial treatment? We have discussed the chemotherapy, the number of cycles. May I ask to the panelists whether one of the centers would have given concomitant chemotherapy and radiotherapy? Because I think this is the approach that the Center of Alessandro Gronchi is usually taking.
Well, in Toronto, we would not use chemotherapy at all. If we're treating the primary with intent for local control, the only times we use neoadjuvant chemotherapy is if we need some cytoreduction to aid with the surgery, and we wouldn't use adjuvant chemotherapy either. But this patient was not an adjuvant situation, so probably would have got, well, definitely would have got chemotherapy post-treatment, post-op.
We are very sorry. We are using in Spain the integration of chemoradiation therapy in a neoadjuvant setting for high-risk localized soft tissue sarcoma, and not with the purpose of shrinkage, but the purpose of survival in high-risk localized disease.
And defined high risk through circulator, or how do you define?
Yeah, we can use circulator, and the cutoff we are using usually is 40% of risk or higher risk of death by sarcoma. It's also useful for that, yeah.
And do you apply the anthracycline while radiotherapy is ongoing, or do you treat with ifosfamide alone?
No, both, but sparing, not in the same days. We are sparing one day at least between the finish of the cycle and the reinitiation or initiation of radiation therapy.
Okay.
And I think it's similar in Italy, I guess.
Emanuela?
Yes, so
We don't hear you.
we use also the same criteria here at Italy. In Italy, we are chemotherapy lovers, but especially in those aggressive cases. I guess that also as a referral center, we always see the worst cases.
We do sequentially most of the time, chemo first, then radiotherapy. This is what we do. I remember a paper by Tom, by the way. Tom, I think you published a paper on the combination of MAD, MAID, and radiotherapy, which where I remember you had concern on toxicity, or am I? Is it a misunderstanding?
We had indeed used interdigitated. We started with a cycle of a MAID, and then 22 gray radiation, another cycle of MAID, another 22 gray radiation, that third cycle of MAID. You know, in those days, the radiation fields were quite large, so I think the morbidity now would be lower. I think more recently we've gone to the regimen that was also used in children's oncology group of a couple cycles of AIM and then concurrent ifosfamide and radiation as a preoperative regimen. I think there's somewhat less toxicity with that in terms of acute skin toxicity. In this particular patient, I think with the presence of metastatic disease at the outset, I probably would have gone with sequential therapy. Start with chemo if responding, then sequential preoperative radiation. But for the high-risk patients, we've also done the concurrent neoadjuvant treatment.
Yeah, in neoadjuvant setting, we also do the combination. So during the radiation therapy, we do ifosfamide only in the weekends. In Milan, they do adriamycin and radiation therapy the same day.
Joanna, you wanted to say something?
Yes, we do it.
Axel, please.
Sorry, we do it in a sequence. We start usually with neoadjuvant chemo and then postpone afterwards the radiation, same as Jean-Yves.
Axel, please.
No, it's same approach like in Toronto. We give consequently the chemotherapy and then radiation therapy. We try to keep alive the patient before surgery.
Frank?
Does anybody of you have experience with hypothermia and radiation therapy, maybe in a palliative setting or even in an adjuvant or neoadjuvant setting?
Charles and
I
Tom?
did not. We did not have hyperthermia at our center.
Nor us.
Nor us.
We have very limited experience with that, and basically, when considering the very high local controls we reach with pre-op radiation and surgery, I personally do not consider hypothermia as really necessary.
So in Tübingen, where I was practicing before, we did quite a lot of neoadjuvant radiotherapy and hypothermia, and we had excellent local control and less wound healing problems than in the Toronto group actually published. So something we think it's quite handy.
However,
Maybe Charles,
we have to
go ahead, Gabi.
we have to be cautious regarding comparison. So the Toronto papers were with 3D techniques, you know. So that's an important point, I think.
Yes, I would like to pass on the word to Charles to comment on their current wound healing complications, because what we are still always referring in this paper in 84 is 40 years ago and was 3D technique. So I think that's kind of unfair to do this perpetuously.
Well, it wasn't even 3D, it was 2D. Yes, our most recent publication, Anthony Griffin and Brian O'Sullivan published it. We've got with IMRT techniques, and we got a 30% wound healing complication rate. So Our current rate is about 30%.
And you
well,
were quite strict
I'm really.
And here we are quite strict on the inclusion criteria. Even, I mean, most of us would only say when we need another surgery, but here also prolonged antibiotic treatment is also a complication. So maybe sometimes what we actually presume as a complication or wound healing problem is not the same for everybody of us.